My name is Alexander, and I shall be talking about the care of the surgical patient, more specifically discussing postoperative pain assessment and management. The first step is to evaluate health history and surgical history. Health and surgical history allows for a more comprehensive understanding of the patient and presenting situation. It may uncover reasons for pain, whether primary or secondary. It also identifies medications that the patient might be taking. These medications may or may not be used for pain, but prove to be useful in selecting appropriate medications that might need to be started so that there are no contraindications between them. Noting allergies is important to avoid any reactions. Next comes primary and secondary assessments. These assessments are important because they can predict if there is pain present, what might be causing the pain, or that pain may be coming or expected. These assessments are incredibly important to evaluate and manage pain in those that are unable to self-report or assess. For example, those in a comatose state, those intubated, or those that are cognitively impaired. With the primary assessment, the A to G acronym is used as a step-by-step guide to assessing the condition of a patient. It proves to be an effective method for life-saving treatment and to aid in prognosis and diagnosis. A stands for airways. The expectation is that it is patent and maintaining their own. Postoperative patients may be intubated or using a ventilator. Airways may become obstructed due to the use of muscle relaxants. The tongue could also fall back into the throat. B stands for breathing. Postoperative patients may be at respiratory distress, especially with the use of opioids. C stands for circulation. Patients could have low blood pressure due to the use of vasodilators in surgery, insensible fluid loss, and loss of blood. Increased heart rate to compensate for low blood pressure is usually present. D stands for disability. We are wanting to measure the level of consciousness. It should return to baseline shortly after surgery. There is a chance of postoperative cognitive dysfunction and delayed emergence, which is more likely to occur in older populations. E stands for exposure. That is exposure to the patient's body for total visual examination. We are to look for any other clues that might contribute or explain what is being experienced. This includes any signs of trauma, damage, wounds, or discoloration. In the case postoperatively, common items include surgical sites, other wounds, possible drains, and implants. This could be reasons why the patients may be experiencing pain. Excessive pain may indicate problems with already identified causes or may indicate one that was not known. This warrants further investigations. F stands for fluids, both in and out. Fluids impact circulation and electrolyte balance within the body. Glucose. Given that the patient would have needed to be nil by mouth, they might have low blood glucose levels. This may impact the level of consciousness. So, how is pain assessment meant to be conducted? There are many different ways to measure and assess pain. They all have their varying effectiveness, best applications to different scenarios, as well as pros and cons. The Wong-Baker Faces Pain Rating Scale and 10-point numerical rating scale are verbal and visual descriptive scales. They are simple to use both by the healthcare professional and the patient. They tend to be useful for those with cognitive or language barriers. Critical Care Pain Observation Tool and Behavioral Pain Scale use body language, behavior, movements, and facial expressions to determine the presence and severity of pain. These scales are useful in those who are unable to self-report or assess. It could be seen as a more extensive version of a FACES assessment, except it is subjected to the healthcare professional's opinion rather than showing facial images to a patient and asking them to choose. PQRST is an acronym that goes further in depth about pain. P stands for precipitating event. What was the patient doing when the pain started? For example, moving or resting. Q stands for quality of pain. Describe the pain and what it feels like. For example, sharp or dull pain. R stands for radiation of pain. Where is the pain located? Is it more than one place or moving around? S stands for severity of pain. Here one could use the previously mentioned assessment tools such as the numerical rating scale to get a value between 0 and 10. T stands for timing. We look at when did the pain begin? Has it changed in intensity since it began? Have they ever had pain like this before? So why do we assess pain? Why is it so important? Well, we assess pain to be able to treat the underlying cause and to reduce discomfort for the patient. We also want to avoid the harmful effects of unrelieved pain. Harmful effects include endocrine and metabolic responses, which then proceed to affect catabolism, glucose regulation, cardiovascular system, respiratory system, electrolyte balance, fluid balance, and cognition, just to name a few. What is the ideal situation when assessing pain? It's to be able to identify it and react to it accordingly. You must continuously assess and reevaluate. Generally, you would want to ask the patient about their pain. Use as many appropriate pain assessments as possible for more data. Intervene appropriately. Ask them about their pain again. Evaluate its effectiveness and the need for any further action. These steps are based loosely off the clinical reasoning cycle, which we mentioned later on. A quote from Brown D et al. Goes, given their assessment skills and 24-hour presence at the bedside, registered nurses are the patient's primary pain managers. So why do we manage pain? Why is it important and what are the benefits? One, beneficence. Beneficence is one of four principles belonging to the biomedical principles. It is imperative to remove harm and to do good. It is considered unethical to keep someone in pain. Managing pain is also considered an essential part of care. We also manage pain to avoid long-term complications such as structural remodeling and sensitization of the nervous system, chronic pain, and long-lasting psychological distress. Pain impacts the early and late phases of recovery, causing ineffective and prolonged healing. Lastly, we manage pain to reduce the neuroendocrine stress response. To safely and effectively assess and manage patients with pain, nurses need to develop sophisticated clinical reasoning skills, sound scientific knowledge base, highly developed clinical skills, and a commitment to person-centered care. This quote from Brown D et al. Is the basis used for managing pain as we continue. First one, clinical reasoning skills. Clinical thinking is being able to judge carefully and accurately. Critical thinking is essential to safe, competent, and skillful nursing care. It is an intellectual process with the ability to think systematically and logically. It's a process of analyzing and assessing thinking with a view of improvement. Here we have the clinical reasoning cycle. The clinical reasoning cycle is a critical thinking model that seeks to aid a nurse in decision making. It involves 8 steps. Feel free to pause here in order to read and understand the cycle and its steps. The second premise to safely and effectively manage pain is having a sound scientific knowledge base. This includes the knowledge of what pain is and its complications when untreated, knowledge of medications, how they work, including dosages, method of administration, etc., and the knowledge of the benefits gained when pain is managed. The third premise is having clinical skills. Relevant skills for pain management include being able to plan and act out a full plan of care, effective communication, documentation, safe drug administration, being able to conduct primary and secondary assessments, and most notably, accurate pain assessment. Being able to assess pain properly is part of managing pain. The last premise, according to Brown D et al., is a patient-centered care. A patient-centered approach directly results in positive health outcomes. This is due to a higher patient involvement where the patient can ask questions and provide information to a healthcare worker and vice versa, as well as getting to know the staff involved. Patients can express their desires more openly and can contribute to their treatment plan, which in turn makes them feel properly cared for and important in the scheme of things. How pain is managed affects more than just the patient. It can affect the family of the patient as well. The family can have a negative experience if the patient is in pain. The way the family feels also directly impacts the patient. If pain isn't managed properly, it could lead to consequences which result in time and resources taken up by healthcare professionals and the healthcare service. What is the ideal situation when managing pain? We would ideally want the patient to experience little to no pain with few to no side effects. We shall now look at the concept of a multimodal approach. Hayes K. and Jordan D.B. state the following. Multimodal analgesia is defined as combining pain medications that have different mechanisms of action to increase analgesia quality, decrease analgesic consumption, and avoid adverse medication reactions. Sindhu, Anza, and Nalini state the rationale for using multimodal analgesia is the achievement of effective analgesia with the additive or synergistic effects of different classes of analgesic agents with reduced doses of individual drugs and decreased incidence of side effects, improved recovery, shorter hospitalization times, and better patient satisfaction. In other words, it is the concept of not relying on just opioids, but also incorporate non-opioids and non-pharmacological methods. We'll now look at interventions to manage pain. Opioids are drugs that work on opioid receptors within the body, for example, morphine. It is a gold standard to which all other narcotics are compared. Non-steroidal anti-inflammatory drugs are a form of analgesia that also have anti-inflammatory and sometimes antipyretic properties. Also, salicylates are a category of non-steroidal anti-inflammatory drugs which hold the same properties. Adjuvants are drugs that can be used by themselves or alongside other analgesics to treat pain and tend to be used more specifically. These include corticosteroids, antidepressants, anti-seizure drugs, and drugs like ketamine. Here we have an adapted form of a World Health Organization's analgesic ladder for adults. It shows a process of managing pain by steps that start with low-level forms of analgesia, increasing at each level. It suggests for mild pain to start with a non-opioid, for example, with paracetamol or non-steroidal anti-inflammatory drugs. For moderate pain or if uncontrolled, move up to weak opioids, for example, codeine or low-dose morphine. For severe pain, a strong opioid is to be used, for example, morphine. Note that adjuvants can be used at any stage. Last interventions, the last interventions that are going to be mentioned are non-pharmaceutical ones. These include positioning, temperature control, ice and heat packs, and music. These methods can greatly impact the level of care the patient perceives to be getting. We shall now talk about the issues we currently face. What is hindering the nurse? Why are they not doing it the proper way? A study by Abdulrahim MS et al. Have led them to the following issue. Patient records reflected that the process of postoperative pain management was not recorded in a comprehensive way. No full plan of care was found in the records, and outcome notes that indicate the progress of the problem of the patient's responses to management were absent. Another issue that nurses may have is the lack of knowledge or hold negative attitudes towards patients that complain of pain. Nurses would also under-administer analgesia due to underestimating pain intensity. Furthermore, nurses tend to use their past experiences to determine the intensity of pain rather than a patient's statement. Oversedation due to opioid use also seems to be an issue that needs to be addressed. The last major issue is that nurses have fears or exaggerated risk of opioid addictions and tend to under-administer it. To improve, we must identify problems and think of ideas to fix them. Adhering to the following suggestions may prove to be effective. Maintain patient-centered care. Work with patients' strengths and expectations to formulate goals and interventions. Remember to be patient-orientated, that is, practicing patient-centered care and aiming to achieve patient outcomes. A study by Abdulrahim MS et al. Has shown that it can be effective to improve nurses' knowledge and attitudes about pain with educational programs. It positively affected the quality of documentation of the nurses being studied, thus reflecting its potential to improve the quality of care for the patients, which indirectly impacts the staff and health service. Aim to practice safe and to be better. To do that, the nurse must maintain the responsibility to be up to date with knowledge and to challenge when practices seem outdated. Abdul-Rahim MS et al. Acknowledges the importance of studying postoperative pain and for it to be integrated in the educational curricula. All of these suggestions aim to better the nurse to deliver better quality care. Better health care means better health outcomes and fewer complications. Well, what does this mean for the future? We may expect to start seeing pain as a more in-depth area of study across many healthcare fields, not just nursing. We can also expect ongoing and future research in the area of pain and management. This can lead to better evidence-based practice, new interventions, better outcomes, and a decrease in the burden of disease. Here are the references. Feel free to pause and look at them yourself. Thank you for watching.